Hello, welcome to ESC TV. My name is Victoria Delgado from Hospital Germans Trias y Pujol here in Barcelona, and I have the pleasure to be here with Professor Stefan Neubauer, who is the presenter this year of the ESC name lecture on innovation, Paul Hugenholtz. It's quite difficult for me to pronounce that name, but I think that his name is already an icon for all the innovation in cardiology. In his lecture, it's really true that in 20 minutes it's really difficult to cover all the different insights and innovation that Professor Neubauer has provided. And therefore we have now the chance to chat more quietly on what made him choose cardiology, what made him choose imaging particularly, which is the spotlight of this ESC Congress 2022, and what are his views on where the field on imaging is moving. Stefan, welcome.
Thank you.
And starting with, what made you go for cardiology and particularly doing research in imaging and providing so many innovations and new developments in cardiac magnetic resonance and also computed tomography?
Thank you very much, Victoria. First of all, it's an absolute pleasure to be here, and thank you for taking time to interview me and also for pronouncing my surname perfectly right.
Thank you.
So that's great. Why did I choose cardiology and imaging? I guess it goes back to the beginning, really. In school, my favorite subjects were biology, physics, and math, and so it seemed medicine would be a good choice with those interests. And within medicine, cardiology, because of the physics and math aspects. Then I think we're all influenced by our early teachers. And so back in Würzburg, where I went to medical school, I did a doctorate degree with Professor Ertl. And also Professor Kochsig was the head of department at the time, and they were great role models, both of them, for me. Then after finishing medical school, I did a postdoc, went to Harvard Medical School, Brigham Women's Hospital, and I joined one of the earliest magnetic resonance laboratories there were in the world, and that was the Harvard Medical School NMR laboratory, which was headed by Dr. Joanne Ingwall, and she's now retired, but Joanne had a huge influence on me, and that's really where sort of we led the ground of much of what was to come. Then going back to Würzburg to do my clinical training in medicine and cardiology and start my own research group, I was lucky that the chair of biophysics at the time was Professor Axel Hase, who is one of the pioneers really again of the early days of MRI. And so we worked together side by side for many years. And I think with that sort of background, I think I was set for a career in cardiology and imaging, and that eventually led me to Oxford.
Very interesting, and you just mentioned excellent mentors, and I think that you have become also one of the best mentors in the world for all the ones that want to join imaging, because after your lecture we just had many mentees that learned from you at your lab, and they have keeping with you connection in order to continue the research. Yeah. And in your lecture, you also gave some key points of how do you see imaging, cardiovascular imaging, which are the key themes of your lecture, which are the key points of your lecture. How would you highlight the main messages that you want to convey with your lecture?
Yeah, so I think the main messages are, where do we need innovation in imaging? And I made a few points because there are many points to make, and I only had 20 minutes. But one is really to move from treating disease labels. You know, not every patient with one disease label has exactly the same disease, to precision medicine, where we can achieve much deeper phenotyping with our imaging methods, and then treat the individual. In fact, first diagnose the individual and then treat the individual and follow the individual up over time. So I think that is certainly, a big point. Another one is that we have spent much of our effort in imaging, I think, to diagnose established disease and advanced disease, and not nearly as much to focus on preventing disease and looking at the very early stages and better risk classification and stratification. And I gave this one example of the fat attenuation index methodology that was invented in my department by Harris Antoniadis, which is information that has always been in CT scans ever since we started doing 64-slice CT, but no one knew how to look at it. And this is, I think, an example of a disruptive technology where now we know how to look at it, and my prediction is that it will have a big influence on how we early risk stratify patients and possibly change both primary and secondary prevention in the fullness of time as we learn more about this. Another topic, I think, is that, as you know, if you want to develop a new drug, in cardiology these days, this usually means following many thousands of patients for many years and spending sometimes hundreds of millions of euros or dollars. And we don't really have very good surrogate endpoints that could massively shorten these trials. And while this is a hard thing to do, I think it's something really worth investigating. And I gave an example, work from Moritz Hundertmark, which is also shown as an abstract here, where we looked at a new metabolic agent and used MRI to look at the functional effects, and then multinuclear spectroscopy to look at various metabolic aspects, so energetics, lipids, citric acid cycle flux, etc., and really fully characterized the mechanism of this drug. And obviously the next step would be to prove that such a full characterization can actually predict what the drug does in the long term. But I think this is something that is worth doing, and if we succeed, I think we can greatly speed up drug development, also de-risk it to maybe discontinue certain compounds that don't seem to be so promising, right? Another topic is to generally reduce patient risk from imaging. So, for example, try to avoid the use of contrast agents in MRI. And I gave one example with the virtual native enhancement technique that our team developed in Oxford, where we can now produce virtual late gadolinium enhancement images without actually having to give contrast. And of course that avoids the side effects and risks of contrast, but it also greatly speeds up the examination because you don't have to wait for 15 minutes to do your late gadolinium enhancement. I guess another topic is to really try to move away from invasive imaging as much as we can to non-invasive imaging. And of course, the enormous success of CT coronary angiography is a prime example here. So I think these are some examples.
And if I take on your words, one of the issues, for example, for me, is precision medicine.
Yeah.
And I like very much the concept that you said is not a patient with a disease, and one disease in two different patients can be completely different. So we should go much more into try to carefully phenotype each patient with that label. But that makes that, for example, we need to use some very advanced techniques that may not be available in all the places. So how can we democratize, in a way, that way of personalizing medicine? How do you envision that these innovations in these imaging techniques will reach a wide spectrum of population?
I think it's a very good and very difficult question. I would say that one possible solution is if we take one method I've mentioned, which is the C13 hyperpolarization method. It's currently very, very expensive, but there isn't really anything in this technology that should make it so very expensive. So I think once it is established that for certain indications, this is a technique that can really give you information that is essential for patient management, I think the costs, just because of economies of scale, can be brought right down, and therefore these technologies can go to many, many more centers. I guess the one other possible answer to this question is we've got to try to first analyze what's going on with the patient or how they monitored, etc., with these many sophisticated techniques that are now being developed in imaging, but then as a second step ask how can much simpler methods give us the same information. And that could maybe include even artificial intelligence, use of the ECG, for example. But I think you first need to establish the database to then train simpler methods to try to do the same thing.
Perfect. We have the audience here, and I would like to thank you for joining us. And perhaps if you have any question, please take your time, go to the mic, and just ask the question to Professor Neubauer. We will be happy to answer all your questions. If you attended the lecture also, if you had any remaining questions, take this opportunity. And perhaps continuing with this discussion on the democratization and also the endpoints of the trials. You just said we have other surrogates that can make the trials not that expensive, that we can perhaps shorten the follow-up because we have the effects of a particular therapy earlier. And for example, the new innovation on the virtual enhancement that you just mentioned and you published last year in Circulation in a particular group of patients with hypertrophic cardiomyopathy, where you compare late gadolinium enhancement with virtual enhancement. Are you planning perhaps to go to other diseases? For example, I'm thinking myocardial infarction. We always have a kind of endpoint, the infarct size.
Yeah.
How can we reduce it? And for that we need contrast. But it depends sometimes very much on when you image the patient, that can change.
Yeah.
If we don't use now contrast and we use this technology, how do you foresee?
Yeah. So we, as you say, have published the initial paper with this technology in hypertrophic cardiomyopathy. We now have a paper in press in Circulation for viability and scar imaging, showing again that this virtual native enhancement technology is essentially equivalent to what we measure with late gadolinium enhancement. Right? And the team with Stefan and Vanessa Ferreira and Qiang Zhang are now analyzing how the method could work in the more acute stages post-MI, because as you know, late gadolinium is not so easily interpreted in the acute stages post-MI, what is reversible, what isn't. We have quite a large database to look at this in Oxford with the so-called OXAMI study, which is led by Keith Channon. And we're going to use that database to also define the acute, subacute, and then chronic stages of necrosis and scar formation. How well that would work, we'll still have to see. At the moment, we have evidence that it works in established scar.
Excellent. One question here. Thank you. Please identify yourself and ask the question.
Well, my name is Rahul Gandhi. I'm a cardiology fellow in New Zealand, and I have a particular interest in global health equity. And I'm very excited by the possibility of innovation in order to be able to reduce health inequities. As we wander past these stalls, we have more and more advanced technologies that are increasingly prohibitively expensive. And so I wondered if Professor Neubauer could speak to how something like this, which attempts to not be the ambulance at the bottom of the cliff, something far more upstream, could help address inequity, if at all.
Thank you.
Yeah. I mean, it's a difficult question, and to some extent we have already discussed this. I think you need both. You need the high-end and expensive research, and then you need to try to extrapolate to much simpler techniques. And I think there are a lot of efforts in this regard around the world. I mean, I'm not an expert on echocardiography, but I know there's a lot going on in echo AI. And so this is something with handheld machines, for example, coupled with AI, where you don't necessarily need a great echo expert present where the patient is, where you can probably get a lot of sophisticated imaging information quite cheaply and quite quickly. So I guess those are the sorts of developments that will go some way answering your question. But of course, I don't have a perfect answer for you. I think it remains some dilemma. But I don't think the answer is to not do the sophisticated high-end research. I think we need both.
And going along with the question, we focus on the technique itself and how expensive can that be and the development. But I wonder also how can we gain the expertise to interpret those images? Because it's not only the technique, but also, for example, echocardiography, as you said, is going on a lot in terms of artificial intelligence and try to make it more democratic. But for example, is there anything on CMR or CT so that more cardiologists, more physicians can get expertise on analyzing the data, on acquiring the data properly? It's not only the device or the machine and the software, but also the expertise. How can we improve or increase the awareness and the knowledge among us?
So I guess there's no question that the training is a bottleneck, but both CMR and CT, cardiac CT, are growing rapidly. So I think every month, every year, there are more centers of expertise in the world where trainees can go and learn, and then they go away and set up their own centers. So I think it will snowball in the fullness of time. I think the only other thing we can do, and that is being done in the meantime, of course, is systematic training courses, a lot of those online, and of course the specialist societies like SCMR, SECT, they are very, very active in this field. And so when you go online to the websites of these societies, you will see lots and lots of training opportunities.
So I hope so, and in many other places, because otherwise your lab will be flooded of many fellows to learn all these novelties.
Right.
So just to wrap up also, where do you think that there are the challenges in this field of cardiovascular imaging, and where do you think the future is heading to?
Yeah.
More or less we have shaped it and spoke about that, but like final words, what would you highlight as a challenge and how we can overcome them in the future?
Yeah. As you say, probably much of it we have covered. So, challenges, moving away from invasive imaging, trying to bring down radiation as much as we can. So, for example, the new photon counting CT is probably going to reduce radiation doses quite a lot. Trying to not use contrast, trying to really bring down examination times. I mean, a typical clinical cardiac MR scan is still 30 to 45 minutes. It really should be no more than 15 minutes, but I think that is a realistic goal. Yeah, those are, I think, some of the issues. And then where the field is going, one of the things I think I did already say is that you can never predict disruptive technologies. So when you look in other fields of life, the smartphone, the jet engine, the light bulb, those things weren't predicted, but suddenly they were there and it changed our lives. Yeah? So you don't know which great invention is around the corner. And in fact, the Chinese poet Lao Tzu said, those who have knowledge don't predict, and those who predict don't have knowledge. So that's why it's a little dangerous to do that. But again, I think those principles, precision medicine, surrogate endpoints, bring down examination time, making things safer for the patient, those are all, I think, general principles, and those methods will win. Maybe one thing I can just say at the end, and we talked about this, is what would be the advice for young students and fellows who are thinking about starting a career in cardiac imaging. And what I would say, and maybe that takes us to the end of this interview, is that first of all, this is a fantastic field. There's so much going on in cardiac imaging. You just have to look at the specialist journals. I mean, we've got Circulation JACC, European Heart Journal, imaging subjournals now, and every month in each of these journals there's a plethora of new ideas and exciting new developments. So it's hard to keep up, but it's a great field to get into, and there's enormous growth potential. Then I would say, find yourself a topic if you're looking to do a research program that you can be passionate about. I think that's really important. Try to find something where you could ask yourself, what will success in my project look like? And it should be something that would, if successful, provide some fundamental advance that really makes a difference rather than just a small incremental advance. And then find a mentor where the chemistry between you and the mentor is right, and the mentor, he or she, has time to spend with their students and help you grow. And then finally, this is hard work, but it also needs to be fun. You really need to be able to enjoy this. Otherwise, you might as well do something else.
Those are very wise words. Thank you very much, Stefan, for this interview. Congratulations with the name lecture. Thank you very much, the audience, for joining us. and I think that your words will remain in our minds to make the field better, to be clinically relevant, and to help the patients.
And thank you
so
for
much.
interviewing me. Thank you so much.
Thank you.